Hi there, Dane here from ARC Health. Welcome to Remote Consultation Masterclass series. Now, before we get started, if you've not already listened to the first part of our podcast with Dr Roger Neighbour, do head over there first. That's episode 1. Now, this episode 2, is the second and final part of our podcast with Dr Roger Neighbour. Now, you can listen to us on Apple Podcasts, YouTube, Spotify, or wherever you get your podcasts from. So I hope you enjoy the episode. Moving that forwards, I guess, based around your consultation model, what modifications do you think you need to make in terms of how we safety net patients when particularly we can't read their body language as easily, or it's, you can't give them that paper information leaflet in the same way?
Yes.
Any advice around those points?
Yes, it's, if I could be slightly immodest just for a moment, it's the whole thing about safety netting. It's one thing which I'm aware that I personally introduced, or at least gave a name to, that has stuck, and I'm actually quietly proud of that. I think that has made a difference, and it makes me feel life hasn't been totally in vain with that. And housekeeping is the other one, which I think is important too, which we'll probably talk about. There are some misunderstandings, I think about housekeeping. It's a mindset thing. In a way, there aren't any rules. You must do this and you mustn't do that, and you should always say X, Y, and Z. It isn't a question of technique. It's a mindset thing. If in your mind constantly is the idea that there's some risk here, and part of what I need to do is to make sure that I don't expose the patient to unnecessary risk, and if that thought is in the back of your mind, and particularly as you approach the end of the consultation, it comes to the front of your mind, then I think whatever is appropriate safety netting ought to flow naturally from that. So safety netting isn't just something you tack on at the end of a consultation. It ought to be part of it ought to be just kind of a background, a kind of counterpoint to a lot of what we say in the consultation, and that even starts even before the consultation. Because if there's one key thing to having a successful video consultation, it's to make sure that the consultation you're having is suitable to be had on video. And that sounds obvious, but I think because of the shift in popularity for all sorts of reasons, I think it's possible for us to overestimate the usefulness and the appropriate of video. There are some consultations that are fantastic for video. They can be time saving and labor saving and all sorts of excellent things, but there are some that it's actually dangerous to do. And if you're having a consultation where finding physical signs is important, then that is not safe to do on video. It may sound a trite remark to make, but I'll make it anyway. I mean, you don't try and feel a breast lump over the internet. You can't do it, and nor should you. So I think if you're aware that the consultation, either in advance, is going to need proper physical examination, then it's not suitable for video. And I think you shouldn't really start a video consultation unless you've already got the potential backup of converting it, if necessary, to a face-to-face quite quickly, to be able to say to a patient, I'm sorry, I can't take this any further because I really actually do need to have a look at this rash. You'll need to come in. I know at the moment, the heat is on from COVID at the time, and at the moment, but that will die down eventually. And I think it's really important that we don't get seduced by the novelty of it, or the fact that it's quite fun to be consulting from home, to lose track of there are circumstances where it actually is unsafe. And the time to safety net is before the consultation, not just to tack on at the end of it. Does that make sense?
Yeah, definitely. So this goes back to conversations you had before around the triaging, to make sure it's the right person we're seeing in the right format or mode.
Yes, I think just staying with triaging, if I can, it's very tempting to delegate your triaging either to a receptionist or, in my mind, a great deal worse, to some kind of algorithm. I will ask a series of yes/no questions, and that gives me the answers to who you've got to see. I think that is awful. I mean, it doesn't work for the phone-up service anyway. For the one-on-one service, it doesn't work for that anyway. Most of those seem to end up with a load of pointless questions followed by "you need to see the doctor." On the other hand, I think the experience that we ought to take from various work that's been done in hospital A&E departments is that to do effective triage, you put your very best person at the front line, the person who really can make decisions and who can sniff out the ones where this doesn't quite fit, and the ones where there's a bit of danger, or the ones where it really is appropriate, to say, well, no, you need to talk to somebody else about this.
Yeah.
So I think there's a balance to be struck there. Obviously, you can't have every doctor triaging every consultation, but neither should you have your junior receptionist or your committee designed algorithm.
Yeah. And I think that's a good point, though, because I think a lot of people now over the next few months are now re-looking at how do they move forwards, because this has been almost a baptism by fire. People have worked quickly to do what they've done.
And done a fantastic job, I might say. Yeah.
So I guess it's now the key points for practice to consider really around what does triage look like to decide on? Is it telephone? Is it video? Is it face-to-face? Who does that and how? And also I think the other point you made, which is really important, which is if you start a video and you think it does need more, but also more importantly, that more is needed now. How do you swap that into a face-to-face? Do we have the capacity? So that's all key planning questions, I guess, really, isn't it?
Yes, indeed. Yeah.
Okay.
I think.
No, go on, Roger. Yeah.
No, I was going to say, because I know video at one point and telephone consultations as well, which are still actually, in fact, more common than video, although much applies to phone consultations as it does to video. The expectations seem to be that this will be time saving. Yeah. It actually isn't. If anything, I think the experience that's coming in is that for a condition that isn't obviously a quick in and out, video doesn't save time. It saves convenience for many people, in terms of not having to trek to the surgery or take time off work, but it doesn't save time. Yeah. And we shouldn't expect it to, and we shouldn't think that we're consulting badly if you can't consult faster on video.
Which leads on to probably my next point and question, really, which is it's the age-old 10 minutes, isn't it? And I think there's a few different doctors have been submitting questions, which has formed part of this podcast. And I think some have been saying that for them, there seems to be a pressure for them to do these video consultations in under kind of 10 minutes, really. And they're finding that with the switch in consultation style, that these consultations are more comprehensive than a remote one would have been in the past. Yes. And they're kind of struggling to kind of manage. And a lot of them were asking, what are your kind of key messages around housekeeping in this context?
Yeah. Well, when you say people feel under pressure, to stick to 10 minutes at max, and if anything, work faster, the adolescent in me wants to know, well, who on earth is making this stupid rule? There's no rule, there's no law that says there's a consultation. Even before COVID, there's no law that says a consultation must be 10 minutes. It's a purely arithmetical exercise. It's if you divide the demand by the number of doctor hours available, it comes to 10 minutes. It's a purely administrative thing. There's no law that says that it must be 10 minutes, not even 10, it must be 10 minutes on average. There's no law that says when it gets to 11 minutes, you're working badly. There's no law that says patients will sue you if they're 2 minutes late, because they don't. And I think one of the key messages, I think that's really important. This isn't about COVID. I think this is me being a grumpy old fart. I want to say to some of the younger generations, if somebody says that you ought to work to 10 minutes, tell them where to stick it. This is actually it's an issue of manpower and capacity in the system. I don't know many doctors in this country or in any others who think that 10 minutes is ample time. It isn't. It used to be less than that. It was just by the arithmetic. When I started in practice, 6 minutes was the norm. But 100 years ago, when I started in practice, you could you could cover the medical agenda in 6 minutes because it wasn't that complex. It's now much more complex. The nature of the problems that people bring to us are much more complex. The number of options that we've got for management and therapy and so forth are much more wide-ranging. There's much more treatment and options available. You can't do that necessarily in 10 minutes.
Yeah, and I think, and we've got lots more allied health professionals also working in general practice now who potentially are seeing some of the quicker, possibly presentations, which means, as you point out quite rightly, a lot of GPs say they are left with the more complex consultations
Sure,
at 10 minutes.
And in a way, that's what it should be. I mean, we've had the training and the experience that enables us to do it. It's for God's sake, it's what we bang on about as being the strength in general practice, that we can handle complexity and uncertainty and comorbidity, and we can delve into the wider context. That we boast about that.
Yeah.
So I think if someone is saying, well, please do all that in 10 minutes, the answer has to be, we can't, and don't you dare expect me to.
Yeah.
Because this then, I think this is really important too, because it ties with what you were saying about housekeeping. Housekeeping is about looking after yourself and protecting yourself. And there's a bit of an assumption these days in that, I mean, obviously far too many people in our profession are suffering from stress and burnout and wanting to take early retirement and really succumbing to the pressure of the job. And there's a bit of a sense out there, it's seldom put into words, but there's a bit of a sense out there that if people can't stand the pressure, well, that's a reflection on them, and they ought to be more resilient. Resilience is a buzzword at the moment. We've got to have resilience. Now, I don't think resilience is the answer to a system that actively oppresses you. There's a danger of blaming the victim. There's a danger of saying to the doctors, you ought to be able to work in 10 minutes, and if you can't, it's because you're not up to it. That is bollocks. Sorry, it's a medical phrase. I did a urology job once, I'm allowed to say that. But I do feel really strongly about that. The answer to time pressure is not to make more resilient doctors necessarily, it's to solve the time pressure. And that's
the system has to change
and manpower, and that's politics, and it's about colleges and government and departments and committees, all that sort of stuff. But it needs to be seen for what it is. Is that it isn't down to the individual doctor to solve a capacity problem in the system. That said too, I mean, as you know, my interest is in the consultation, and quite a lot of teaching I was doing before COVID closed down a lot of stuff was very much around the issue of time. Everybody feels time pressure, of course you do. That goes with the territory. And people will quite often ask, well, how should we change the way we consult in order to get it done in 10 minutes? Well, there's a limit to what you can do with consulting techniques, because quite a lot of the things that you can do to relieve your own work time pressure aren't to do with how you consult at all. They're outside the consulting room. They're to do with, have you got enough doctors? Have you got, what's your policy on locums? Are you training the receptionists right? Are you using the nurses and the nurse practitioners and the other disciplines? Are you using them right? Nothing to do with how you consult at all. So I think we have to, this issue of time and 10 minutes, we have to think much more widely outside the box than just how do I run my consultation, because there's a limit to what you could do in that time, and there's a limit to what you should do in that time. End of rant.
No, no, valid point. And I think many practices are doing it differently. So, for example, the practice I worked in New York, and working in New York, many have moved to 15-minute consultations. Others, but I do know there are colleagues of mine in London who are still very much on 10 minutes that I'm aware of. But I guess the big question you raise here is, what are the resources that you have? Who is doing things? What are the systems in place? And it can't just all be solved by resilience.
No, indeed.
Yeah, completely. Because there's nothing worse than being stressed every appointment because you're trying to fit in.
But you're right. I mean, one of the things which is nice about general practice is the degree of freedom we do still have about how to organise our working days. And there's no law that says a surgery is 12 10-minute appointments without a break. There's no law that says that.
So everything's possible, and we need to relook at it.
I know it's not easy. I'm not trying to lighten it, of course. But I think we actually have to locate the problem where it really is, and it's in capacity. The problem is capacity.
No, that's important. So kind of moving on from that point really to the more handing over part of your model in the past, I think a lot of doctors say in a moment that there's a lot of health anxieties from patients, and I guess obviously understandable with COVID, and they're worrying about whether they can contact their doctor in a timely manner. And a lot of people are saying that their patients are struggling to take control of their health at this time because of those anxieties. And I guess a lot of GPs are now finding that these video consultations or even any remote consultation is becoming lengthier as they try to spend more time really encouraging people to take responsibility for their own health. So I wonder what your take is on kind of the language we could use or the tips we could get across to try and do that handover of health, particularly over a video consultation.
Yes, that's really, really, really hard, isn't it? Because how shall I put this? I think we sometimes overestimate the impact that we have on people, on patients' lifestyles. I mean, I'm sure you have countless times said to somebody gently, politely, helpfully, etc., you could really benefit from losing some weight. And they say, oh, I know, doctor, yes, you're absolutely right. And they go home and do absolutely nothing about it. And same with smoking advice and exercise, all the usual things. And I think we have to acknowledge that GPs or any kind of medical profession are not necessarily the best people to be doing that. I think there's a limit to the impact that we can have. And I think in terms of well, what's the alternative then? I can't for a moment think that anything you could say in a 10-minute video consultation is going to persuade somebody to lose 3 stone in weight. I just don't. I think that's hoping for the moon. On the other hand, you do know what your local resources are. You might have some nurse-led groups, or you might have some patient-led support groups and so forth. I did a similar conversation with this for a thing through the college a couple of weeks ago, where there was the most interesting presentation by a guy called Alex Maxwell, who's a GP in London somewhere, who's organising video groups for patients with shared problems, overweight problems, or diabetics, or people hypertensive, or people recovering from strokes, or whatever. With some enormous success about that, and I'm not the expert to go to, but make a note of the name Alex Maxwell and Google it, and you'll find your way to some excellent advice about how to take some of the responsibility from this off the GP's shoulders. I think it's, in a way, one thing which doctors are addicted, which GPs in particular are addicted to, are the idea that we are actually all things to all people. I think most GPs suffer from or have a "please love me" syndrome. We like to be liked by our patients and thought well of and admired and so forth, and that's not necessarily a bad thing, but it is an undercurrent in many doctors' psychology, my own included. And part of that can express itself by saying, you bring me a problem, bring it on, and I'll solve it for you. We don't have to be the experts on everything.
No, and obviously that's a challenge given the broad spectrum of things we cover, and sometimes I find it's the patient's expectation of us as well sometimes.
Yes.
But behaviour change is difficult, and you're quite right to point out. I think brief intervention wise, my own interests are more in physical activity and getting people more active. But there's a couple of good studies talking about brief intervention being that if we give brief advice, for every 12 patients or so that we give that brief advice to, one patient might change from an inactive person to active. I think smoking's much larger. I think numbers are 50 plus.
Yes.
So there's some potential, but like you said, we have to be part of a joined up network. It has to signpost the right person with the right skills.
I think also being slightly more constructive about it. We tend to couch our motivational advice in terms of health effects. Stop smoking or you'll get lung cancer. Lose weight or you'll get a stroke. And well, for many people, health issues are not their primary motivators. And with some individuals, it might be a case of stop smoking because actually your breath smells and I'm not surprised your girlfriend has gone off you. Or lose weight because if you get a stroke, they won't let you fly to Australia to see your grandchildren. Not health issues. And I think most people who outside the medical profession who work in this field of lifestyle advice and lifestyle change will say the key thing is to tap into the individual's key motivators.
Yeah. Not
to assume that just because they're talking to a doctor that health issues are their key motivators.
Yeah.
No, and I think that goes. Yeah. So I think that's really important. Not to assume that it's a health issue, but to try to find out. Well, what could you do? What if you had a stroke? What would that stop you doing?
Yeah. Yeah. And I think so. There's a couple of points you make there that hopefully listeners might want to go away and have a look at. But behaviour change is so complex. Some of the stuff you're talking about is around understanding the patient enough to then understand their motivations. But also there's other things like capability and opportunity for them. What can they do? Susan Michi, UCL base, has got a behaviour change wheel, so worth having a look at. Stephen Rolnick has his motivational interviewing model as well, which has some value and people enjoy that. So all parts worth looking at.
Okay. That's really useful. Really useful.
So moving on, one last thing on consultation. I want to finish off on some of the more kind of medical education bits. But considering the handover part of your model, we've just talked about that. So I think we've taken off some kind of key points there around what we need to talk about, but it is a challenge. So do have a look at that. And Alex Maxwell is someone that we should probably try and get on actually and talk about some of the things he does.
Should. Yeah. He's good. He presents it well too. So.
So in terms of medical education, then really to finish, in terms of medical education, what are your thoughts and advice for TPDs, trainers, doctors providing medical education, particularly around how to teach consultation? Should any of this change in the way we teach this now to our registrars?
Yes, yeah. I guess that's really interesting because it's at risk of sort of going over some past history. The UK and the English-speaking world in general, in which I don't include America because they don't speak English there. But in most parts of the world where English is the vehicle for medical education, emphasis on the consultation has been quite a theme for many years. And it dates, I think, probably dates back to the days of Barlint, which was the 1950s, no, the 1960s, 1950s and 60s, that original work on doctor-patient interaction. And most of the theoretical stuff, most of the models and the teaching and the training in any systematic way worldwide is actually UK derived. And I don't know quite why that is, apart from the accident of history that took the Barlints from Hungary to London in the 1950s and 60s, because they were absolute pioneers in looking at communication and the interaction. And I think it probably does stem from the fact that in the NHS, right from its early days, there has been, well, regardless of what we were talking about earlier, there has been that pressure to do a lot in a short time. And unless you manage that interaction, you can't do it. I mean, you can't, in general practice, as you know, you can't hope to do hospital medicine only faster. That's not enough. You can't do it that way. We have to tackle it in an entirely different way, as you know. And most of the work that's been done, and the books that have been written, and the models that have been published, and the advice and the training and so forth that's been done dates from the 1980s, 70s, and 80s. It goes back to Byrne Long in 1976, and the Pendletons' book came out in 1985, my own in 1986. Calgary, Cambridge was the most recent, and that's 1992, I think. But since then, there's been very little original or different stuff taught in terms of theory about the consultation. And the world has changed hugely since then. Not least, when FRCGP became mandatory in, was it 2004? Was it?
Can't remember, but yeah,
sometime around then. And there's been very little fresh thinking about the consultation since then. And I think, in a way, I think those of us, I mean, quite a lot of the people who have contributed, myself included, are still around on the block. And it's very tempting to peddle the same old messages and to think that it's possible to consult in 2020 in the same way that it was possible to consult in 1990. And I think we've actually made things in terms of the formal teaching about the consultation. I think we've probably overcomplicated it. I think we've made it more complicated than it is. And Byrne and Long were the original ones, and they had six phases, didn't they? And then the Oxford book with the Pendleton and Locke, they had 7 tasks, and I had 5 checkpoints. Calgary and Cambridge at the last count have 71 micro skills. Dig. But you can't handle that sort of stuff in real time, in real life. It's too complicated.
Yeah.
And I think the time is probably right for a rethink about how we try to teach the consultation, because it isn't enough just to hope that people can intuitively develop an effective consultation style. You know, you can't just sit there in your consulting chair, brimming with goodwill and medical knowledge, and just hope that it works. You have to make it work.
Yeah.
And I think we've probably overcomplicated things, which is why, can I get a plug in here?
Go on, yeah, go for it.
Okay, I've got a new book coming out later in the year called Consulting in a Nutshell, which simplifies things beautifully, aimed particularly at ST3s and people early in their careers. End of plug. And I defy you to edit that out of the edit. But seriously, As I said, I think earlier in our consultation, essentially the task of consultation is quite simple. Someone who comes in with a problem needs to leave with a plan. It really is as simple as that. And the strategy for doing that is actually not that complicated. It's work out what the problem is, and the key message is work out what the problem is first, before you move on to the solution.
So from a training point of view, you're almost identifying that while there is lots of things in the past that still are current and workable, there is definitely an opportunity here with the way things are going for someone potentially to even put their own name on it at this point in time. But I guess this is where the next few years will really inform what the new models look like. And
I think, seriously, linking it with with what's prompted this discussion in the first place, which is COVID and its impact. It's almost impossible during COVID not to consult in a more doctor-centered way. We've had to impose some structure on the access process. We've had to impose certain forms of triage. And certainly consulting by video, because it's not so easy to have the spontaneous ebb and flow between two people. Most video consultations are a bit more doctor-centered. That's not necessarily a bad thing, but it does mean that the pressure at the moment is for us to revert to a way of consulting that I thought was on the retreat to some extent, which is for us always to run the show. So I think in all the forms of teaching, I mean, we've got a fantastic body of trainers and program directors in this country, second to none in the world. They are superb, and I think it's really important that particularly at this time, that those of us with any input into education keep our eye on the ball and try to keep a sense of, well, actually, what are the core values here? I mean, the core values are delivering good, sound clinical medicine, of course, but also being alert to the wider context and some of the buried stuff and the hidden stuff and the stuff that takes a bit of insight and empathy and understanding. I mean, we need to try to find ways of preserving that, and there's no single way of doing it. But I just think that we mustn't, in our enthusiasm for video and telescoped forms of consulting, and under the pressure of a pandemic, let's not lose total sight. When the pressure eases off a bit, let's try to remember what actually are the core values here, that we're actually trying to deliver something that revolves around the person opposite us, not necessarily around the medical textbook or what the nice guidelines say.
So
that was good. That was a second rant.
Well, you're entitled to your opinion. One take I want to ask you about is the CSA and exams in general, because I know you've had stuff to do with this, and you're still involved with this. I guess firstly, if you're able to give us a quick overview on what's changed during COVID, how things are happening now, and also then your take on CSA moving forwards.
I ought to make clear that, because actually I think in your introduction you said I was an examiner. I'm not now. I haven't been for many years. I stopped being an active examiner in 2003 because I was then college president, and one of the rules of the game are that the college president is the ultimate court of appeal if somebody appeals against an exam fail. And obviously there was a conflict of interest there. Having said that, though, ever since then and still to this day, I'm actively involved in teaching and preparing candidates for CSA preparation courses and so forth. So I still have my network of friends and connections within the exam, so I do know what's going on. As you know, the CSA is impossible to run under COVID social distancing rules. It's not on. So from I forget when it came on stream. I think it was the end of April or thereabouts. The CSA is currently suspended. And has been replaced by something called the recorded consultation assessment. And the technology of that is that people doing the FRCGP now will upload onto a website recordings of, I think, 13, it might be 12, I think it's 13 of their own real life consultations, which might be face to face, or they might be recorded consultations themselves. But they upload real life consultations, and those then get looked at by examiners and assessed against the same criteria that the CSA was. So the marking approach and the things that are being looked for haven't changed at all. It's just that what the examiners are now looking at are recordings of your real consultations rather than simulated ones with a role player.
Okay.
It's also slightly cheaper. Actually, it's a fair bit cheaper at the moment.
Always good.
Because, well, because people don't always realise this. The exam is as an act of college policy is not profit making. It never has been. It covers its costs. It doesn't actively make a profit, much to the disappointment of the treasurer, but it doesn't. The CSA is labour intensive. You have to pay role players and you have to pay backfill locum cover for the examiners. That's why it's expensive, for no other reason. Whereas with the RCA, all you're paying is a certain amount of time for the examiners, without having to pay role players and so forth. So it's actually cheaper to run. But in terms of what it's looking for nothing different. It's still looking for, can you deliver safe medicine in a compassionate way?
Yeah.
And it's assessed in the same way. So in terms of preparation for any of the people who might be listening or watching this, there's no need to prepare for the RCA in any radically different way from how you would have done for the CSA, except that with the RCA, the choice of cases is entirely in the candidate's hands.
Yeah.
And so how you choose a portfolio, there is some skill in that.
Yeah.
If you send in 14 cases of people with a cold, 13 cases of people with a cold, because you can't go wrong there. On the other hand, you can't be seen to be any good either.
Yeah.
If on the other hand you send in 13 really difficult testing cases, you'll probably not do terribly well, because how could you? You're only a young doctor.
Yeah.
So there is some thought there, and if I can get another plug in, not to myself this time, but the RCGP website has got some really good advice with some good clinical examples about the type of cases that are appropriate to submit. And quite a lot of questions that people ask about the exam and about the RCA are answered. It's actually, the RCGP website is not the best in the world, but the exam section of it is.
Yeah. Okay.
It's full of really good stuff about there with some practical examples and so forth. So do check it.
Yeah. So have a look at
the college,
site.
by the way, is at the moment is intending to revert to the CSA as soon as the social distancing rules allow.
So question for you on that first final question really is, so CSA wise, once it comes back into play, can you see a change in exam style happening? And if so, what might be the case?
I would think so, wouldn't it? Because I mean, the CSA is intended to be a test of how you function in real life or realish life. And real life has changed. Real life is now going after the CSA, after COVID rather. I'm sure we're not going to continue to do 90% of our work remotely, but we probably do 40-50% of our work remotely. And in that case, any kind of assessment of how you function in the real world will need to include some kind of assessment about that. How that gets translated into the exam format, I have no idea. I mean, I would expect that discussions like that are in hand as we speak. Yeah. And the college has already made it clear that it will always give 6 months notice of any change it makes to the regulations.
Yeah, so people have time.
So people have. Yeah, that's really important. It's a high stakes exam, and contrary to popular belief, the college is not trying to play tricks on people and screw money out of them. It really isn't. Perfect. Nobody ever believes examiners when they say that, but it's true.
No, perfect. To be fair,
I think the answer is watch this space, but I expect it will change. Yeah.
My own CSA exam, I remember thinking it was a reasonable set of cases that I could have seen. It wasn't anything that was overly complex. I thought they were reasonable, but
why would you? I mean, there's no pleasure from an examiner to be gained by watching somebody dig a pit for themselves and fall in. That's not. I mean, nobody likes to see that.
No. Perfect. Well, Roger, firstly, thanks so much for your time today. We've covered a lot of things and it's been fascinating. I wanted to finish with one last thing from you, really, which is any kind of key final messages from your top tips before I close?
About video? Or?
Video consultation, mainly,
Yes, a couple. First, at risk of repeating myself, don't try and feel a breast lump over the internet. Think safety. Secondly, in terms of how you improve and manage it well and develop a style of doing it that you can be proud of and think, well, that's okay. Take advantage of every opportunity you get to get some feedback on how you're doing. And I think the very best way is actually just to watch recordings of yourself. I mean, I think virtually all the platforms allow a recording of you to be reviewable afterwards.
Yeah.
Watch yourself. So it's good advice for doctors, anyways, isn't it? And you try and put this more succinctly. Try to become aware of the kind of doctor you come across as.
Yeah. Yeah, and it always looks different how you think it went when you're when in the room, isn't it? So
doesn't it? Yeah.
Perfect. Well, look, thanks again, Roger. So thanks for joining us, and thank you guys for listening. Hi there. You've been listening to the Remote Consultation Masterclass series. Now, in the next episode, we'll be interviewing Dr. Anthony Waring, who's a consultant in sports medicine and also musculoskeletal medicine. And he's going to be talking to us about the rise in remote working and the challenges that this brings for musculoskeletal presentations. As always, do keep in touch with us for future episodes by clicking the subscribe button on Apple Podcasts, YouTube or Spotify. See you on the next one.